Well, first, I'm thankful really to be included in this discussion for the 2 days. It's been a wonderful meeting from my perspective, very different views and so on. What I'd like to do is tell you what I'm going to talk about. There are going to be 5 general areas that I would like you to hear about. One of them is responsibility of the Army and of society as a whole to the soldier. The second is the needs of the individual soldier vis-a-vis the group needs. And these are vastly different. And we're going to want to differentiate between what I would call current acceptable modifications, enhancements, alterations, whatever you want to call that, from what we're proposing to do for the super soldier. So I'd like you to consider the modifications for the super soldier to be essentially doing irreversible behavioral, psychological, and motor function of the operator. That is something we haven't done intentionally or by ignorance. And that's a fundamental difference that can't be clouded or shouldn't be clouded. Separate what's irreversible and what is reversible. I'd like you to think again, we're recruiting and accessing people age 18 to 40. The expected life expectancy for a person born 10 years ago is 100. That means we're responsible for the people having 60 more years after they're separated from service, with all the responsibilities that that accounts for. The next point is what are the known lessons learned from where they've done modification on human beings and under what conditions. And then when are invasive procedures non-reversible, justified, and that's based clinically on cost-benefit ratios. Cost-benefit ratios not to the community, to the individual, to the patient, and to the soldier. And finally, this is a similar discussion we had back in '09 at a NATO conference, European, US, Canada, and so on, where we came up with what are the ethical considerations from a NATO perspective in human irreversible modifications. So first slide, please. Yeah. So the responsibility of the society should be do no harm to the soldier, whether intentionally by ourselves. We're not talking the adversary. We're talking about us doing harm to the soldier, or by ignorance. And by ignorance, it doesn't mean intentional evil. It means we don't understand scientifically the outcome, not tomorrow or the next day, but 5 weeks later, 5 years later, or 40 years later. That's critical. Second is preserve the mental and physical wellness of the soldier from accession to a normalized old age, to 100 years. And finally, acknowledge that the soldier, as soldier, hasn't agency to provide informed consent. And the reason he or she can't provide informed consent is because they don't have the knowledge what's going to happen 10 years down the road. And part of informed consent is understanding adverse outcome in a command environment. And finally, the soldier actually is under command structure. So in the same way, a child, an individual in prison, or anyone under someone else's total authority cannot provide informed consent, neither can the soldier. Next slide. And I'm ready to beat me up when I finish with this. What are the individual autonomy and homogeneous group needs? Individuals vary. It's a bell curve distribution. One question to ask yourself is if I took the top 5% of that bell curve and trained them to the highest level they would have, would that be equivalent to doing the bottom 50% with all the invasive modifications you want to do? If that's the case, then there's a problem with the modification. The next one is what we're doing is dietary supplements, pharmaceuticals, physical supports that have a transient effect in performance are ethically reasonable. Today, we give uppers to B-2 bomber pilots who are flying for 40 hours. If we didn't give them the uppers for the 40-hour flight, they would have errors, and we know that functionally from 20 years ago. This is today, 2017. This isn't the super soldier. This is a soldier. So let's take a look at the next slide. So when do ethical concerns arise? Number one, we know that if you give drugs, it's not only electrical activity which is modified, but you have essentially a signal device and you have a receiver device. What the brain does is when you goose up the firing rate, the receptor elements that are receiving it are shut down. That's super inhibition. Conversely, if you lower their firing rate, you have an increase in receptor problems. So what do we know clinically about that state? If you give acetylcholine esterase inhibitors, what you end up after 6 months to a year is tardive dyskinesia, continual movement, shaking, flailing of the limbs, to such an extent that the individual can't function by themselves. It becomes a family burden, and it's no use to the Army at that point. We have example also with limb amputation. Now, limb amputation, if you have wounds and things of this sort, that's completely appropriate medically. However, if you're doing limb amputation, in order to get a super soldier who you can fit with a prosthesis and then drive that prosthesis to make him or her run faster, that's an example of a modification that's going to enhance transiently an operative's ability to cover territory. What happens when that fellow or woman leaves? And we have clear examples, phantom pain. Pistorius, a great example of an operator who has no legs. You've seen him from South Africa, the runner. And yet you have a very super performer with incapacities of all sorts resulting from that. So at the point where long-term cognitive and psychological and behavioral changes are induced by physical modifications, that's difficulty. And when the long-term consequences, adverse, 30 more years after separation occur from the modification, you have again difficulties. I work with traumatic brain injuries from soccer players, football players, and so on. We can't predict what percentage of the people with these traumatic injuries are going to end up with what we call TBI clinically, but I can tell you it's on the order of 30 to 35%. Now, that's not horrible, given that means 60% don't have that. But if you're dealing with a large population of soldiers who you are causing intentionally to have adverse effects, that's not going to be helpful economically, socially, or for the structure of the Army. Next slide, please. We talked about the up or down regulation with the cholinergics. These are known outcomes with tardive dyskinesia, the flailing. So we do today deep brain stimulation of individuals with Parkinsonism. And what these deep brain stimulation does is if the Parkinson patient can't stand by himself or herself, or has such extensive tremors that they can't control food or whatever else of the sort, with deep brain stimulation, we can get the people to stand. That's a big deal. We can get the patient to feed themselves. That's a big deal. On the other hand, these Parkinson patients are typically 50 years and older. Number one, the expectancy of life is 10 to 15 to 20 years at the outset. And so, do we see anything that's negative in these patients? Well, yeah. 20% of the individuals to 30% have chronic infections because of the lead from the external surface into the deep brain. Second, they have microvessel bleeds into the head. And so you end up with gliosis, scarification of the brain. Is that a problem? Well, it's a problem, but the cost benefit to the Parkinson patient is they can stand, they can walk, they can feed themselves. The cost-benefit ratio in all of this is what's of concern. For the patient with Parkinsonism, the cost is significant, but the gain is spectacular. For an 18 to 40-year-old, healthy, young, very clever, highly trained person, to have 25% of these people with chronic brain infections, bleeds in the head, in order to gain a transient competitive edge in running, is probably not reasonable. I'll put it as plain as that. Next slide, please. So when is it justified to do the modifications? To permit partial recovery in a patient with a major health problem. Again, the cost-benefit ratio is what? All procedures have a cost. There is no treatment, pharmacologically or surgically or radiation-wise, that does not have an adverse cost to the patient. And I'll tell you that's true with radiation therapy for cancer. It's true for chemo, and all of these lead to autoimmune disease. But if you didn't do that for the patient, you would end up with either a dead patient or a non-functional patient. The trade-off in a sick person is clear and understood. The trade-off to an 18 to 40-year-old only has negative consequences. Next slide. So what are the considerations for military applications? Again, our soldiers are physically and mentally probably at the highest state of wellness that they're going to ever be. You've selected them to be operators under duress, and they function very well. We heard about special operator selection. These are the highest of the highest, both mentally, physically, emotionally. They're active between this. And the question is, must we compromise their function after separation from the Army and their fiscal, social, and ethical issues? And so what justifications can we give for extreme invasive manipulations, and what have been offered? Next slide. So the positives that have been put forward, really not only here, but back in '09 for the Sofia meeting, is the increased survival of the operator, increased mission completion, and parity with the adversary. And if it's not parity, it's power, dominance over the adversary. Well, let's take the last one first. Because in current structure force that we have, commanders are dealing with operators who are driven to the highest performance standards that can be achieved. If you're now doing an enhanced operator and the commander has current doctrine in his head or her head, rather than adapting to what you need to do with a super operator, the expectation is going to be driving that super soldier to a much higher risk rate than would be expected under non-super soldier enhancement. Well, is that going to lead to increased survival or decreased survival of that particular operator? My suspicion is it's going to be, unless you change command structure, it's going to lead to decreased survival of that enhanced operator. If we talk about survival of leg amputees, higher than following major invasive brain treatment. And so one of the notions, you probably have heard of Kurzweil's book, Singularity. And the Kurzweil proposition, US author, a very brilliant fellow, and we have a lot of the folks who were at the IA, an insertion essentially of computers connected to the head either remotely or directly, but it's leads from computers going into the brain to stimulate appropriate brain regions, so you have both analog systems and multi-parallel systems operating consistently. The question here is that person, when they're separated, even if there's not all the negative consequences that I'm proposing to you, when he goes back to mom and dad and brother and sister, is he brother and sister who I left 10 years ago? My suspicion is he's not and she's not. That ability to reintegrate, and we had the young man sitting over here at the table asked yesterday, what are the effect of the modification of the person irreversibly on reintegration in society? I didn't hear an answer to that. And the notion is that that person, and we heard it from Tony and from my colleague, that person is now not the same person. Self-image is not the same thing. And we know this in football players, in powerful athletes who have stepped down from their sport. After 5 years and 6 years, you have very high depression rates. Thank you. Depression rates and a variety of other elements. The last slide, I think. Yes, in the NATO rules, there were really 4 principles. Is the intervention informed and voluntary? And my assessment, having been on human subjects committees for 8 years, University of Wisconsin, this is clinical stuff. If you are not having agency over yourself, by definition, it's not informed. Second, is the intervention safe for the individual and operational environment, meaning collateral damage, threat to friendly force, and the like? If you have a super soldier operating with changed cognitive awareness, behavioral awareness, perception of threat, you have a compromised operational environment. Is the intervention based on safe as determined by science in clinical or operational units outside of the clinic? And I will tell you, we have very few examples where that's done except with uppers, and so we know for 10 years now, operators have been doing this. With the non-reversible, we will not know it's non-reversible probably until after 3 to 4 years of use. And finally, has due diligence been applied and all other alternatives exhausted? Is there a leadership issue in the employment of soldiers and equipment in battle when we have irreversible modification, and are there other tactics and strategies? And because we have a bell curve, I'll suggest we have another alternative, and that is a selection option rather than modifying the whole troop elements that we have. So anyway, thank you very much, and I hope there's some questions.